Hi guys, can everyone hear me okay? We're going to get started here in just a minute. So let me know in the comments, wherever you're joining from, whether that is Instagram, YouTube, Facebook, wherever, let me know. I am going to get started here in just a minute, and I want to make sure everyone can hear me loud and clear. A couple weeks ago, I did an entire webinar and no one could hear me loud and clear, so it was a little awkward. So sounds like you guys can hear me and things are going okay. So looks good. We can go ahead and get started now. We have a lot of content to cover, so I want to just jump right in because I've an hour and a half sounds like a lot of time, but really in the scheme of things, it is not, especially when we're talking about geriatrics. So just to introduce myself to you guys, my name is Dr. Annalise Caffery. I am a board certified family nurse practitioner. You guys call me Annie. I'm super casual. My background is in geriatrics, of course. It's what I love. I love our geriatric population. The ongoing joke in my family is that I'm trying to retire as soon as possible, and all I'm ever looking for is a bingo group to join. So I get a lot of harassment from my family members saying, you only care for the old people because you just are looking for a bingo group. So um, that is kind of where I've ended up. I just love older adults. I love the amount of knowledge they have and so much that they bring to society, all of their years of experience. And there's a lot of health problems associated with it. So I did my nursing background in the emergency department, and I did like the fast pace there. And people that say that you'll never see fast pace in family primary care, they have not worked in family primary care. You get a lot of acute care cases or people with a lot of different chronic illnesses. So that is just a little bit about why I love geriatrics. Jamie, I see your comment here that on Zoom chat is disabled. It should be open, but yeah, I'm not seeing anything on my end. And that is outside my tech realm of expertise at this point. So go ahead, drop any questions in the Q&A. We're also going to be using Slido today. I'll walk you guys through how to sign up for that or how to get in if none of you have ever used Slido before. So no worries there. As we do practice questions and case studies, you guys will be able to comment. That makes it really easy because people joining then from Facebook or YouTube or Instagram can all get in the chat and can all put their answers in the same spot, so I don't have to look at 20 different screens. So welcome to our geriatrics review, guys. I could not stress enough to you the importance of geriatrics in studying for board prep or anything. Before we jump too much into it, to go over some disclosures, as you guys probably know at this point, Archer Review is accredited by the American Nurses Credentialing Center, which is amazing and really speaks to the quality of content we put out for you guys. Because of that, we're able to offer you one contact hour for continuing education or however you need to use that. If you signed up through Zoom with your email, you'll go ahead and you will get that certificate saying you got that contact hour. But in order to get that, you do have to be present here for 80% of the course. So, this is an hour and a half. We say for, about an hour of this webinar, you need to be present, and then it will go ahead and get that out. But also, just as a heads up, I don't have any financial relationships with any individual. None of this information is being used for anything outside of that. We're just giving you this information. I used up-to-date sources. That's all cited. And if anyone has questions, they can go ahead and feel free to reach out. Now to look at our learning objectives, what we kind of overarching, geriatrics is a population. So then you say, well, what's your webinar really about, Annie? If you're just talking about a population geriatrics, that's a lot of information to cover. Well, today we're going to focus in on really what are the differences. When we talk about geriatric, why do we care? Why do we have to segregate, not even segregate, but separate them from the rest of the population? Why do we call them geriatrics rather than just treating any other adult? It's because there are physiological, psychological, functional changes that happen as we age. And so with that, there's going to be a huge impact on clinical presentation for disease, pharmacokinetics. So that means what we prescribe and how much we prescribe of it. And then also the disease management. So we're going to look in depth at a lot of those things. A lot of the specific diseases I'm not going to get into today, like, for example, chronic obstructive pulmonary disease. You guys all know that COPD is seen pretty much exclusively in a geriatric population. That's going to be covered in our respiratory webinar, which we have, once or twice a month. So join that one if you're looking more specifically for that. That is also an amazing webinar. This, we're going to look more at how, the differences that you would normally see, not just the regular treatment for any adult with it. Then we also want to differentiate geriatric syndromes. And geriatric syndromes is like this umbrella term that we'll get a little bit more into later in the webinar. But things like dementia, delirium, depression, incontinence, that's considered a geriatric syndrome. How do we differentiate these? And what are the clinical characteristics, the risk factors, screening tools, treatment mechanisms? So we'll dive into that. And then lastly, we're going to look at current guidelines. We want to look at what our preventative care is. We want to look at what our disease management is. What are we doing? What are we recommending to our older adults to keep them healthy, to keep them happy, and to keep quality of life? Remember, the thing I say about geriatric population is that quality of life is the currency. You can have worked your whole life, become a billionaire. You got tons of money. You're ready to retire now at 70. If you are in poor health, that money really doesn't mean much to you. You can't travel. You can't spend time with your grandkids. You really just spend the rest of your years sitting in a chair, in a recliner in your family room because of poor health. So I always tell every one of my patients, quality of life and health is the currency of old age. That is really what we trade. It's what we sell. It's what we want to gain as we get older, is health and good quality of life. So now that we've gone over those learning objectives, hopefully you guys will feel like we really covered all of those for you guys to prep you for your boards or just really to see geriatric patients. We can hop into Slido. So Slido is kind of an app it's an app we use for questions, case studies. As I said earlier, it lets everyone join in at the same time. So if you go to slido.com, you can join here. You can type in just Gero number 4 NP. That will get you there if you don't have a phone to scan this QR code, or you can scan the QR code. It will take you right there. So let's see if people are able to hop in. I will go ahead. We'll start it. Once again, that's that QR code right there that you can use to join. Let me see if I can I move that? Well, hopefully that still scans. There's that QR code. If anyone has any issues with that, you can just go ahead and type in Gero number 4 NP. So you don't need to go ahead and add the hashtag. The hashtag on the website when you type in slido.com is already there. So just that Gero 4 NP. And then once you guys get in, you can go ahead and comment where you are joining from. Let me know what state people are coming from. This is a really good way to let me know that you have made it in and are A-okay with everything. I know tech stuff can be Michigan and Wisconsin. We got some like neighbors up there, up in the north. Are you guys just freezing your heinies off? I mean, I guess you can't really answer that in this poll. I'm just gonna assume it's very cold. I'm joining today from Utah, and it is actually 70 degrees Fahrenheit here today. We are randomly, I think a big storm's coming in. It's kind of like the warm before the storm. Oh, California. I hope you're joining from Southern California on a beach. That's my hope. Missouri, Brazil. My brother lived in Brazil for a couple years, down in Juiz de Fora. And so I went and visited him and I ate my body weight in pão de queijo. DC, another Wisconsin joiner. Well, guys, this is awesome. It's really fun to have Arizona. That is actually where I was born and raised. My mom called me today and said it is sunny and warm there. So we can go ahead and we'll move on to the next one. The other thing I want to know before we really jump into deep content is how confident do you feel about caring for geriatrics? I know sometimes, like when I was in school, I love geriatrics, so I felt a little bit more confident, but pediatrics was really hard for me. Okay, we've got some ones out there, guys. I am gonna change that. Oh, we've got a pretty good smiley face there. That's good. I like that. Okay. Kind of some of you guys are in the middle. You feel iffy on it, felt like you could do better. Okay. Well, I love this, guys. This is awesome. This gives me a really good baseline about where you guys are at, just so that I know how much to focus in on things. And we'll look at this again at the end of the webinar, just to kind of keep a pulse point on how well you guys feel like we covered content and if it really helped boost your confidence at all in seeing geriatric patients. They feel, I think scary sometimes because there is so much going on with them and so much that can go wrong. And you're talking last years of life. If you're caring for a 90-year-old geriatric patient, it's not like they're going to live another 50 years. And so a lot of that stuff can be really hard. It's awkward conversations about end of life care, about palliative care, hospice. Do they have a will in place? What treatments do they want us to implement? And so it can be really overwhelming. Oh, whoever's the hard eyes, I love it. I love to see it, guys. Okay. So that's kind of how Slido works. We'll do more questions that are practice questions or case studies throughout the webinar just to keep you guys engaged and make sure that I'm covering content in a way that makes sense to you guys. So I like to start with board preparation gold is what I call it, because I just think this is a really good way for you guys to like me a lot. This is most of your guys' probably first time catching a webinar from me. And so I know a lot of you guys email us or take the product and you just want to know, what do I need to know for boards? What do I need to know for boards? What do I need to study for boards? And while I get the idea behind that, we do also, of course, want to just make sure that we're prepared as clinicians to care for patients. But I get it. Boards is probably the biggest test you'll ever take in your life. It's the biggest test I've taken up to date. And I was anxious. My whole family was excited for me to be done with boards because I was just a little nervous Nelly about it, and that's totally normal. And so let's go over the things that, based on research and what the two certifying bodies have put out are the most commonly tested subjects. So as we look at that, we are really looking at, first off, cognitive disorders. That is going to be a huge subject point. It's really going to be highly tested. So you're going to want to know the differences between things like delirium, dementia, depression. What are early signs of Alzheimer's disease versus late signs? They like to ask about that. Treatments for both of those. And then delirium, like what are the causes and treatments of delirium? That is often misdiagnosed in primary care. And what screening tools do we use? What's the preference and when would you use one screening tool over another screening tool? That's a really good place to start studying. Polypharmacy and medication safety. We know polypharmacy is a huge issue. Research across the board really ranges in what percentage of older adults have polypharmacy, but it is a huge percentage. We're talking over half the population. You want to know Beer's criteria, medications to avoid. Beer's criteria is really huge. We're talking that's a massive document. And so it can be overwhelming. I would never tell you to just go memorize Beer's criteria. That is really hard to do. But from the most recent update, when you look at medications to avoid, things that you should not be prescribing, or if you get a patient who's already on it, you should look at deprescribing. I would know those medications. Also, dose adjustments for renal and liver disease, function in older adults. We know that goes down as they age. So you want to know drugs that are excreted or metabolized in the kidney or the liver. What are those really common drugs like metformin, for example? Everyone knows that metformin, you need to check GFR on that one. It is super renal excreted and very hard on the kidneys. Deprescribing strategies. How do we deprescribe medication? Whether or not you are the provider that put a patient on that medication, how do we start to wean them and take them off of it? And then medication side effects that mimic illness. That's another really great one that they love to test on. Not that they're trying to be tricky, but they want to test you on the things that are often overlooked or that are often patient safety issues. So when you're picking what to study, make sure you're prioritizing those patient safety issues. An illness that may be overlooked because it is written off as a medication side effect that may be written off because it looks like, a common disease, and you say, oh yeah, you've just got a cold, it will get better. When really it was a side effect for a medication. So know those. Falls and functional assessments, you want to know risk factors, prevention strategies, how we assess ADLs versus IADLs. I know that is probably terms you haven't heard since nursing school. But super important that you guys understand those, know them, know how we test them. Gait and balance changes. Once again, how do we test gait and balance changes? When do we implement assistive devices for walking? When do we refer out to PT? They love to ask about referrals and interdisciplinary communication, like how we work with other people on our team, whether that is um, uh, a farm guy who's going to help manage diabetic medications, or it's a PT guy or an OT guy who's going to help manage gait and balance issues. So know those. Chronic disease nuances. You don't need to get too nitty-gritty specific, like you have to memorize every little thing, but they do love to talk about hypertension and diabetes management. Those are heavy hitters. I could talk about hypertension and diabetes all day long. I could do a 6-hour webinar on the two of those. There's a lot of information to know, a lot to cover, a lot of education to cover when you're treating a patient between the two of those. That's hard to fit into one visit, especially with how fast visits in the United States can be right now. And then atypical presentations, you want to know that. So we know that in older adults, because of some of those physiological changes we're going to go over, they don't always present the same way as a younger adult or a child presents with an issue. So you want to know what would be different so that you can recognize it. AFib, stroke prevention. We're not going to go over this today. I included it though, because chronic disease for geriatric patients, you want to know the CHAD scoring system. So know that scoring system. That is a really good one to memorize. I'm not going to promise you're going to get a question on it because there's a lot of content they could ask questions about, but that is a highly tested piece of information. So that's a really good one to know. I'd star that one. And then anticoagulation, risks versus benefits. When do we prescribe it? When do we say, hey, quality of life, age, not worth it? We'll take the risk of the PE. We'll take the risk of, the infarction. And then preventative health. Last one on this page, you want to know age cutoffs. They love to ask about those, patients on the border when it's like, does she need another pap smear? I don't know. So know those. There's a lot of great apps. A lot of our screening recommendations come from the U.S. Preventative Task Force Service. They actually have an app you can just get on your phone. You can just download it, and it will. I use it all the time in clinic. I mean, I will be upfront that if you recognize that by graduation, or even if some of you guys are joining and you're already post-graduation, you won't have anything memorized. You won't everything memorized at least. You will feel so much better. I remember my last semester of NP school. I was stressed. I was like sweating at night because I was really nervous that I hadn't memorized everything yet. I didn't know everything there was to know, and I was going to go take care of a patient and accidentally kill him because I didn't have, every little nuance memorized. Use what is at your disposal. I love Up to Date. I love a lot of these apps. I have a link in here later for an app that I think is really well done that's useful. And then lastly, fall and fracture prevention. So, you want to know the differences between osteoporosis, osteopenia, when we start treatment, what's first line for that. And then last two here, geriatric syndromes, which we talked about in our learning objectives, especially incontinence types. You want to know that. So what are the different types of incontinence? What's frailty? How do we intervene in frailty? Sleep disturbances and how we treat it safely. When you go into clinic practice or when you're doing your clinical hours, I promise you will see a lot of sleep disturbances in older adults, and you will see a lot of treatments that are not evidence-based practice or what is most safe. So you want to have that memorized. Pressure injury staging, that is probably going to have carried over for nursing for you guys. I wouldn't spend a ton of time on it, but definitely look at prevention strategies and how we catch it early. And then lastly, that ethics, safety, and end of life. Remember, one of the things I said is awkward about taking care of geriatric clients sometimes, if you haven't practiced this conversation or you've never had to have it before, is that who's going to make decisions for you? What decisions do you want to be made? Have you made that known? Have you voiced your opinion on what you want done? So all of that stuff is pretty important to go over. And then lastly, you've got advanced care planning and hospice criteria. As primary care providers, we are frontline, depending on the state you're in. If you're full practice restricted or, in between, you can put patients on hospice. That was my first job out of grad school, was working with hospice patients in palliative care and, making decisions for providers to help with, do we put them on hospice? Do we not? Are they still a good candidate for hospice after 6 months? And so you'll see these throughout my lecture quite a few times. These post-it notes in different colors or clinical pearls, you'll see those in pink throughout the webinar. That's a pretty good indication that that's something to write down, something to highlight, something to remember. It's something that I have found important in my practice when I took boards. Or it's my soapbox issue. So a little bit of variety there. But I want you guys to know, do not forget that 25% of your board is going to be questions about geriatric patients. It may even be more than that. Geriatrics is a huge portion of boards. You're talking that's patients really 60, 65 and older. That's a huge portion of the population. And so therefore it's a huge portion of the questions about who you're caring for. So don't forget this population, don't understudy them. You want to make sure that you know these 7 items really well. And that way you guys will walk into boards, you'll feel super confident. Okay. So we'll jump into the first thing. Why is geriatrics different? What changes? So why do we manage them differently? We want to start with the why so that we can get into the rest of the stuff. You're going to see normal aging in pretty much every single body system. We're talking the heart, the kidneys, the lungs, the brain. Everything starts to slow down and change in function. I like to think of it as a car. You know, you might have a friend, or you may be the person. I was the person in college that drove the car with like 250,000 miles on. And, you know, we called her old reliable. Like it was just the car that kept on chugging. You know, people thought it would have given up the ghost a long time ago, and it just kept chugging along with those 200 something thousand miles on it. So that's kind of our older adults. Their bodies still work. It's a functioning car. It may not have the nicest leather. It may not have all the new features or upgrades, but they still work. It maybe just takes a little bit longer for the AC to cool down the car, or maybe it takes a little bit longer for you to get up and going. That's all normal. It still is a working car with a lot of value. It just changes. So we want to look over what's normal. When we talk at the heart, when we talk about the heart, what we're looking at is cardiac output declines. We know that. And you guys can drop any questions in here if you have questions about that. But we know that the heart just kind of starts to wear out a little bit, just like an old car. Like it still pumps, it's keeping them alive for sure. But even if someone who stayed healthy, their heart function, it starts to decline. The heart doesn't pump as hard and your blood pressure drops. So your cardiac output overall is just a little bit decreased. With that, you also have arterial stiffening. Even in someone who ate good, lived a healthy lifestyle, exercised, arterial stiffening can be normal. You know, arterial sclerosis, when you start looking at that, cholesterol deposits that lead to myocardial infarctions, that you're talking about something different. But overall, the vessels just stiffen. They're not as loosey-goosey as they used to be. They don't react to blood pressure changes as well. And that overall raises systolic blood pressure. If any of you guys have ever left a piece of plastic, I grew up in Arizona, I told you guys that. We had a swimming pool, and it was really important that if we use the pool stuff, we put the pool items away after. Because if you leave them out in the sun, they'd get kind of hard and crispy. They're not as soft anymore. They're not as bendable and pliable and likely to break. I like to think of human arteries a little bit the same. As they age, you know, they just get damaged a little bit and they're stiff. That's going to cause systolic blood pressure to raise and cause hypertension. So hypertension becomes more common as patients age. It's why one of the things they love to test on is hypertension management. It's pretty darn common in older adults to have hypertension. And then one of my board pearls specifically is that isolated systolic hypertension. So that's when we're talking the top number is high, but the bottom number, your diastolic blood pressure, is normal. That is almost always seen in my geriatric patients. Like if I'm going to see isolated systolic hypertension, it is in my geriatric patients. That's way more common, and it's because of that arterial stiffening. And I'm going to be honest, isolated systolic hypertension can be a little bit harder to treat than run-of-the-mill hypertension, in my opinion. It usually requires more than one medication to treat. So if you get a board question and it has more than one blood pressure medication, don't be surprised that isn't like, whoa, that's a no-no. We don't put older adults on more than one medication. Most of them will require at least one medication to get that blood pressure under control. We have body composition changes. We know that body fat changes. So You're going to have increased body fat, which I have a lot of my older patients are sweet old ladies, and they come and they're, I always ask, like, what, if you wanted me as your provider to help get you healthy in one or two categories, what would you pick? And they always tell me, oh, just that 10 pounds, that nagging 10 pounds of fat I can't seem to get rid of. And I always tell them, oh, that's just a little bit of cushion. That's why I tell my grandma, she is frail. When we start talking about frailty syndromes, I love the lady, but she does not have very much meat on her bones. And I'm always telling her, Grandma, you got to get a little bit more meat on your bones. Falls are really big. And with that, you've got decreased bone density, decreased muscle mass, thin skin. All of that is going to contribute to issues with falls, which we will talk in depth in a little bit later. So they do have a little bit increased body fat. I don't tend to worry about it too much, but know that it changes how drug distribution and absorption happens, because you've got more fat cells, less body water, less muscle mass. So all of that kind of is happening in body composition. Then you look at the lungs. They've got reduced lung elasticity, which is going to help contribute to, chronic obstructive pulmonary disease, like we talked about earlier. It's going to lower their vital capacity. They can't get as big of a breath in, not as much air exchange is happening. And then when they breathe out, it doesn't bounce back like a new rubber band. I wish I had a ponytail on my desk. If I had a new ponytail, that's got that fresh elastic and you let go of it, it just bounces back fast. They don't have that as much. So they have to breathe out a little bit longer, a little bit slower to get that same amount of air. They don't have that forceful exhale. I said gas exchanges decrease. So oxygen saturation is not going to, don't see a patient whose oxygen saturation is 90 and be like, yeah, that's normal because gas exchanges decrease. That isn't normal, but it would be normal. They're not going to hit as 100 as much as they did when they were in their 20s and running marathons. They also have a blunted cough perception, which is one I put on here because I think it's one that we often forget about or just feels weird. Like, why would you care? They don't cough as well as we do, and they don't have that drive to cough as much as we do. So when they get a lot of gunk in their lungs, they're not very good at getting it up, which is one of the reasons that like pneumonia in older adults is really dangerous and, can cause a lot of respiratory distress symptoms pretty fast. So that's something you always want to monitor in an older adult if they've got crackles in their lungs, so they're gunky or an X-ray shows pneumonia. You want to monitor them pretty close because they may not be able to cough that up. Same as a newborn. They just don't have that good cough reflex. And it also maybe might not be the great indicator. I don't want you to write off pneumonia when a patient comes in, but they haven't had a cough really, because that cough reflex is blunted. So that's something to pay attention to. As you look at how does the brain change, mild memory decline happens to everyone. It's just the way of life. It's like I said, it's that car just slowing down a little bit. It is usually going to be short-term and recall memory. So it's going to be like, they can't remember what they had for dinner last night. Totally normal. I'm not concerned about that. Your board pearl there is that when they start getting lost or family members are saying, hey, they're just forgetting all sorts of things that they should know. Or they can't complete tasks, like they can't cook themselves dinner anymore. They can't drive anymore, get themselves to the grocery store because they're getting lost, or they can't remember to brush their teeth. That's when I start to say, you know what, this isn't normal. This is no longer mild memory decline. It's a bigger issue that needs to be tested. So that would be kind of the difference there between normal and abnormal. So with that mild memory decline, look for those signs of slower information retrieval. It may take them a little bit longer to get someone's name, but they're still going to get it. They may look at their wife and be like, not their wife. That was an exaggeration. They should be able to recall their wife's name. If they can't, that would be more worrisome to me. But you see that neighbor walking down the street and you say, John, Jeff, oh, it's Jake. That's normal for aging. That's really normal. That's not worrisome. Processing speech just slow. So they're going to get the accuracy at some time. Accuracy is maintained, but processing speed slow. Just remember that. That's important to know when you're differentiating on board questions or in the clinic between what's normal cognitive changes and what's something that you need to refer out. Metabolic changes. So GI motility decreases, stomach acid decreases, so it takes them longer to absorb stuff and they don't absorb things as well. more prone to constipation because of that, more prone to drug toxicity because of that. If you guys are starting to see the vibe here, this is why I like to go through this in my geriatrics webinar. I think it's important that upfront you understand why things are changing, so you understand why you care. Why do we care about how much of a renal, excreted drug or a GI absorbed drug we give a client that is over 60? Well, because their stomach moves slower and they have less stomach acid, so the drug's not absorbed as much. Hepatic metabolism slows, so that also is going to affect drug clearance, once again increasing the risk for drug toxicity. Renal changes. You've got the GFR starts to drop about 8 milliliters every decade after 40, which 40 is not geriatric. 40 is not that old. 40 is just young, but we know that kidney function, our kidneys are constantly filtering. You got to think that at some point they start to wear out a little bit and say, hey, you know what? I'm ready for retirement. I want to slow down. So 8 to 10 milliliters a decade is what I remember that is going to decrease. So that's why we always test for serum creatinine and estimated glomerular filtration. And that is actually one of my clinical pearls there, is that serum creatinine, it often remains normal. It's not a great lab value in older adults because they don't have very much muscle mass. And so that kind of balances it out. It's high because of poor kidney function, but because they don't have very much muscle mass, that kind of decreases what we normally have in our skeletal muscle. So then you kind of say, oh, that balances out and it looks normal, so it's going to mask renal impairment. You get that lab value. If it's the only one you run, you say, oh, you know what? Jake's got great kidneys. His serum creatinine's normal. We don't have to worry about it. When actually he does have renal impairment. So we always order with a serum creatinine a estimated glomerular filtration rate. Never pick just that one test on your boards. Then we also have bladder elasticity. Okay, I felt like my Zoom lagged for just a second, but I have a good internet connection, it says. Okay. As I look at the bladder losing elasticity, so you're going to have patients with increased need to urinate. We know that is a common complaint in older adults. They wake up a couple times in the middle of the night to pee. That's probably the complaint I hear the most in my older adult patients, is that they just keep waking up so much to pee. It's so darn annoying. And the trade-off there that kind of sucks for them is that, their bladder's not elastic, so it doesn't stretch as much when they have to pee. And therefore, with that, it means they have to pee more frequently, less space for the urine to go. But then also their pelvic floor muscles are weakened as well as we age. So then the actual act of urinating can be difficult in and of itself. Like that can be hard for them. So kind of a takeoff there. And then the other clinical pearl I didn't talk about on this one, I didn't want to spend too much time, is just that an aging pancreas, which happens to every adult as they age, pancreases get older at the same age your body gets older, increases the risk for insulin resistance. And then insulin resistance, we know, causes higher fasting glucose levels. So you won't see as low fasting glucose levels in an older adult, even if they're healthy, as you would in a younger adult. So because of that, we're a little bit less tight on glycemic control, just because, especially if they're frail, we don't want to try to drop them too low. They will have hypoglycemic symptoms and be kind of miserable. Falls are increased, confusion's increased. So as our clients start to get older, we say, hey, you know what? We can take a step back or two with that A1C control. It's one of the things that's different about chronic disease management in older adults. That's why we're talking about all this stuff. Sensory changes. I'm not going to talk too much about these. Oh, these are backwards. Sorry, guys. That's a typo. Oh, man, I wish I could fix that right now for you. Presbyopia is difficulty focusing on near objects, and presbycusis, which I probably mispronounced both of those. Disclaimer, I'm not great at pronouncing. is that high frequency hearing loss. It's why when we have an interview with an older adult client, we want to talk in low and slow tones. That will give them the best chance of hearing us. We also want to make sure we're at eye contact and they can see our mouths so that they can kind of put that lip reading with what they're hearing. They have decreased peripheral nerve conduction. So the nerves move slower, just like everything else does. Just like an older adult jumps up off the couch slower, their nerve conduction overall throughout the body is slower. That means they're slower to respond to stimuli. Their reflexes are not as fast. That was a fancy way of saying their reflex is slow, which means we want to give good education about preventative things, because whereas if I touched a hot stove, I would pretty quickly pull my hand back because that hurts. They're not going to have that nerve conduction as much. And they also just have decreased sensation, especially in diabetics. So they may be burning themselves or injured and not even really know it to respond to that stimuli. So we want to make sure that we have a lot of protective measures in place. Like we educate our type 2 diabetics to not walk around barefoot, that they should always have socks and shoes on to protect their feet. Speaking of feet, our proprioception, so knowing where our body is in space, that's like if I close my eyes, I can say like, yep, I can put my finger to my nose. That's proprioception. That's decreased. And so is their vibratory sense. So we're talking this just their sensation. It mostly happens in their feet first and kind of travels upward. So it would be kind of abnormal to have someone who had really intact sensation in their feet, but not as much in their hands. I'd be kind of wanting to do more testing on that. So know that it starts in the feet. That's more normal. Sensation just decreases and it gets worse over time. It's why we want to be really careful and protective of those arteries and those nerves down there, not damage them with diabetes. We don't want to damage them with heart disease, because once they're damaged, it can cause a lot of other issues down the road. And it just gets worse and you can't really treat it. Lastly, I think this is the last one. Yep. We've got the sleep-wake cycle changes. So they have more nighttime cycle awakenings. So that is honestly multifactorial. As we talked about earlier, their bladder's less elastic, so they have to wake up frequently to pee. But also, they just don't have the same hormones. Their sleep-wake cycles, what their pituitary gland puts out, it's not the same. They don't produce as much melatonin. It's at different times, so they are more often to nap during the day, sleep less at night. They have a lot less REM time. They don't get nearly as much REM, which we know that REM is really important for good cognitive health. So that's a lot of research is coming out thinking that maybe that's one of the reasons that we see so many cognitive changes in older adults, is those changes in the sleep-wake cycle. So it will be interesting to see what further research comes out there. One last little board pearl for you about how geriatrics are different. Don't mess up on a board question the difference between persistent insomnia and excessive and normal, like, oh, they wake up once to pee in the night. A client or a patient who's telling you, like, I can't fall asleep. Like, I lay in bed with the lights off for 4 hours and I can't fall asleep. And then I'm waking up at 2 in the morning. Or they tell you they're falling asleep while doing activities during the daytime. There's an excessive daytime sleepiness scoring tool that you can use that will ask them questions like, do you ever fall asleep doing activities? Do you ever, do you need a nap to get through the day? Do you feel sleepy when you wake up? That is kind of used to look at sleep apnea, but I also use it in my geriatric patients to look at, is this normal? They're getting older and they don't sleep as good. It hurts, laying in bed, their hips start to hurt and their knees, and, their spouse that they've been married to for 60 years snores loud. Or is this something abnormal that needs to be evaluated? Like, do I need to order some sleep apnea testing? Now we can go ahead and jump in pharmacology and polypharmacy. And remember, this is one of those things I said, really know this for board. This is board gold. They love to ask questions about this. First, let's look at what the risks are for polypharmacy, what it is, and what changes in the body with pharmacokinetics. Polypharmacy, which you guys may know, it does have a definition. It's not just like, yeah, it's around here. Like, they're probably considered polypharmacy. It is defined as 5 or more medications. And that includes herbal supplements, that includes over-the-counter medications. Any patient old, young, brand new baby, you yourself, if they take more than 5 supplements, over-the-counter medications, and prescription pills, they are considered to have polypharmacy. And the risk with polypharmacy is that when they're taking that many drugs, every drug you have has an adverse effect. That's the thing about medicine, is that we're so often weighing those pros and cons. We're constantly asking ourselves, okay, well, this drug, lisinopril, for example, causes a cough. Super irritating. Like, no one wants to have a chronic cough. That's no fun. But we know that hypertension is the silent killer, super dangerous. So is it worth it? We're constantly weighing that. When we get clients that are on, 5, 6, 9, 10, 15 different medications, those adverse drug effects start to build up on each other because a lot of medications work similarly or have the same side effect. If you take 2 drugs that have the side effect of constipation, your risk of constipation is now doubled. You're going to be more constipated than you would be if you were on only one of those medications. So that's something to look at. Also, with that, you've got drug to drug interactions. You have some drugs that are safe on their own, you add another drug in, and it becomes very, very dangerous. And then we have something called prescribing cascades. I talk a lot about it in when I talk to nursing students as something to look for in providers. Now that you guys are becoming providers and going to write your own prescriptions, this is something you want to make sure that you are constantly self-assessing for. Prescription cascades are this idea that a client gets a symptom that is a symptom caused by a medication. Lisinopril is a great example of this because we already talked about it. Lisinopril, we know, as an ACE inhibitor for hypertension, causes a chronic dry cough. Your client comes in, they tell you, I've got a dry cough, Annie. I need something for it. If I'm, having a bad day, I'm being lazy, I'm not doing my medication reconciliation, what I say is, oh, they've got a cough, I'll prescribe Tessalon pearls. That's going to help their cough. Send them on their merry way. Oh, well, now the Tessalon pearls have a side effect. They come back next week. They've been taking these Tessalon pearls and their lisinopril, and they say, oh, Annie, you wouldn't believe it. Now I've got, and it goes from there. One medication causes a symptom that we write another prescription for, that causes another symptom that we write another prescription for, when really we could have maybe just changed the hypertensive med to a med that doesn't cause a chronic dry cough and saved all those other drugs that we put the patient on. So we really want to avoid prescription cascades. With your physiology recap, I put it here in like a little image. I find this to be the easiest way I learn. You know that metabolism slows with age, so drug toxicity. We also know that we have reduced renal function, which toxicity, we can't get rid of drugs as fast. So what is that going to cause? We do A plus B. That is going to lead to slower metabolism of the drug, causing more adverse reactions. And that is going to be when you start looking at things that are dangerous and we start worrying about our patient. Diazepam, I put this one here as a example. Examples was how I learned best in grad school. So if this just confuses you, ignore them. But for those that do like examples, diazepam, benzodiazepines is a really good example of that. You have a half-life of like over 80 hours in older adults. So you're talking, if you give a client a benzo, 80 hours later, over half that drug is still in their body. And then you give them, 80 hours is what? 72 hours is 3 days. So it's over 3 days later. They're taking another benzo for their anxiety. And now they've got 1.5 times the benzo in their system. So that is something you really want to look at and know that half-life is prolonged and that that's a risk for toxicity. You don't need to memorize for the boards every little specific drug's half-life. You don't need to memorize any of them. But in clinical practice, make sure that when you're prescribing something, that's always something you look up. Also, you want to not forget that when we're talking about medications, because of these polypharmacy risks and these pharmacokinetic changes, we do everything slow. So we start low and we go slow, especially with drugs like blood pressure or thyroid. Like if a client needs 25 micrograms of thyroid hormone, levothyroxine, we start with like 12.5 at first. Like you really start with a very low dose to keep the client as safe as possible. Now we can move on and look at Beers criteria. The most recent Beers criteria came out in 2023. They write an update every couple years, just because it's so important that providers know what medications they should avoid, what medications are safe, what medications use with caution, etc. This is, of course, not even a fraction of what is included in Beers criteria, but these are the ones that I said are about the most important. So go ahead, take a screenshot of this if you want, write them down. This webinar will also be uploaded to YouTube and Facebook after I'm done here, so you can see it again there. If I know we have a lot of content to move through, so we're moving a little fast. If you want some of these again. But these are the drugs I would know the drug examples of them, and then know why we do not prescribe these. So these are drugs that should be avoided in older adults. So any one of these drugs you say, you know what? I'm not going to prescribe this one. That's not great. So things like cognitive impairment for benzodiazepines, fracture risk, car accident risk, confusion for anticholinergics, urinary retention, constipation. You want to know all those and know that it would be something you don't want to prescribe or that you want to deprescribe. Like I said, Beers criteria is huge, massive, massive. I included a QR code here to an app in the Apple Store that is put out by the American Geriatric Society that writes the Beers criteria. I think it's maybe $5 a year, maybe $10 a year. Don't quote me on that. There are some free features, I'm pretty sure. So I would recommend everyone download it. But if you're looking for apps that you feel like are good, high quality medication apps, I would recommend this one. I really like this one. I think it's well done, and it kind of goes through all the summaries, and you can look up specific drugs to see where it falls on the Beers criteria. So it's searchable, and I really like that feature. Now let's talk about deprescribing. Remember, this is one of the things that I said they like to ask about on the boards, because all of a sudden you've been a nurse, you've been at the bedside, you've been the one giving medication. Now we get to prescribe the medication, and we also get to deprescribe the medication. We can take clients off medications. We have that scope of practice. We can say, you know what? I don't like that you're on this blood pressure med. This is not great for you. Or, your last provider wrote a prescription for a glyburide and you're having hypoglycemic events every day. I'm going to take you off that. That's totally within your scope of practice when you are caring for a patient. And so you need to understand how you deprescribe and when to deprescribe. I always say that deprescribing starts at a visit. Every single time you meet with a geriatric patient, you should be performing a med reconciliation. That is just across the board standard guidelines. It should always be done at every single visit. And with that, you need to look at the dosing. So are we accounting for renal dosing? So we need a lower dose of gabapentin if their creatinine clearance is less than 60. So if that clearance is less than 60, you got to decrease that dose of gabapentin. So we should always be looking at what's their renal function like, and does that mean we need to adjust the medications? You want to avoid over-prescribing, like we talked about that prescription cascade. Another term for that is a pill for every ill. I like that one because it kind of got that alliteration going, rolls off the tongue really nice. A pill for every ill, that is problematic. Every time a client comes in, we don't need to be prescribing something. And that was something I definitely had to learn as I started out in practice as a new nurse practitioner, because I'm going to be 100% honest with you guys. Prescribing something is the easiest thing to do. I mean, especially with e-prescribing nowadays, and clients love it. Patients come into you and they want you to fix a problem. And so they want you to tell them oh, you have a cough, you need a medication for that. Oh, you've got, a stitch in your side, you need a medication for that. Your hands hurt, medication. We feel like if we give them a solution to their problem, it makes them happier. But we want to treat root causes. We want to have more of an upstream approach to healthcare in the United States. That is one of the big goals moving forward with healthcare, is taking more of that upstream approach, not just giving them a pill for their illness, which is then going to cause a side effect that we give them another pill for, but instead treating the root cause with non-pharmacologic means whenever possible. So that's all really important. You also want to, like we said, those non-drug therapies. Are we looking at physical therapy for chronic pain, or are we putting them on long-term opioids? Long-term opioids and long-term should never really be used in the same sentence unless we're talking hospice, which hospice in and of itself is less than 6 months to live. So when you start looking at it that way, even that really shouldn't be long-term use. Just look at other things that you can prescribe or educate your client on that are not just pills. That is really important for deprescribing. And for board questions for geriatric clients, it is almost always the right answer. When you start looking at doing something that is not pharmacologic, that's a pretty good, like, I would never immediately write that off. It'd be like, oh, hey, is that going to do enough for my patient? Would be kind of what I asked. And if I think it's a good place to start, that's going to be my answer that I submit. So let's give this a little test with a case study. This is open-ended, not multiple choice answer. I put it over here. So you guys should be able to see it here. Yeah. So once again, you guys can scan that QR code if you've lost it, or once again, go to slido.com and type in Gero number 4 NP. So let's look at this. You've got an 80-year-old female. She's presenting to the clinic with complaints of chronic dizziness. So she's got some pretty bad dizziness. You were an awesome provider. You did a med rec, and that revealed that she's been on a long-term use of alprazolam for situational anxiety. So what is your next course of action going to be? Do you have any other questions you want to do? What do you think we should do? What should we order? What should we tell our patient? Look at that. You guys are smart cookies. This is why you're in advanced practice. Wean her off, taper her, stop the med. I love those answers. Change it. That's another great answer. I think that one is often forgotten about with a lot of these patients as we say, oh my goodness, they should not be on alprazolam. Of course, that's what's causing her dizziness. She's on a long-term benzo, which, as we know from our, couple slides ago, is on the avoid list for older adults. But I mean, if she has situational anxiety, we don't want to just say like, tough luck, lady. Like, you're stuck with your situational anxiety because you can't be on a benzodiazepine. So make sure that if you are going to wean her, that you have a plan in place to monitor that situational anxiety and to see what else she may need that we could switch her over to help with that. See how frequently she takes it. I love that answer too, guys. That is another great answer. Because we need to know, like, it's for situational anxiety. It was probably prescribed as a PRN med. Is she taking it every day? Because it really shouldn't be taken every day. If she's taking it, once every couple months, maybe the dizziness is caused by something else. So that is a great answer to look at. I really love that. Great job, guys. I will go ahead. We can jump back here. Let's see what I had written when I wrote this. Yep. Reduce the dose every 10 to 25% over 1 to 2 weeks to taper her off the medication and prevent withdrawal. So that's about what is recommended currently, the most up-to-date guidelines when we're tapering benzos. You don't have to have that memorized. It's a good number to have in the back of your pocket so you know how fast you're going to get her off. 10 to 25% over 1 to 2 weeks. So at the fastest, you're talking 8 weeks really, because you'll do 25% over 2 weeks, another 25% over 2 weeks, another 25% over 2 weeks, and then that last 25% of that medication over 2 weeks. So it is kind of a low and slow process. Remember, we said everything in the human body slows down as we age. And so with that, they just don't bounce back from, like, you can't just stop a medication cold turkey that maybe they did used to be able to stop cold turkey without it causing issues. Great job, guys. Okay. Don't forget, I gave this one its whole own slide. Wow, I must have been feeling fancy. If a new symptom arises in an older adult, always suspect medications first. That should be your first thing. Like, if we are detectives with our little eyeglasses walking around and we see new symptom, that should be like red alert bells going off in your head saying, did they start a new medication? We should probably do a med rec and see if they're on any new meds, taking any new supplements, taking any new over-the-counter medications, if they've started taking more of a medication they used to be on. Those are all questions you want to ask yourself. Acute confusion could be caused from an anticholinergic, drug like a TCA or a new opioid rather than dementia. Don't always jump to the scariest or the most chronic or actual disease process. I would recommend you first jump to medication. That's an easy one to rule out. If you do a med rec and they're like, yeah, they've been on these drugs at this dose for 10 years and this is a brand new symptom, it's probably not one of the meds they're on. So check that out first and then move on to other issues. We have now moved in to geriatric cognitive and mental health. I'm going to have to move faster, guys. I'm sorry, I'm taking too long and I have a lot of stuff I want to get through for you. This is board prep gold. They love cognitive and mental health stuff on the boards because it is so under the scope of primary care. I mean, yeah, we refer a lot of this stuff out. If you're diagnosing Parkinson, you're going to refer that out to a neurologist. 100%. But a lot of the treatment stuff like depression, we're first line there. We're catching the depression. We're catching the dementia. We're the first ones there. So it's high yield. You should expect multiple questions on your boards for this. Quick Slido question here, guys. Back to our Slido board. What is the most common type of dementia? I'm just going to give you just like 1 or 2 minutes, so jump in the poll quick if you can, and let me know what you think is the most common type of dementia before I hop back in and continue lecturing because we're a little behind schedule. I literally need to invest in one of those horns so that I can give you guys like a little cheer when you get answers right, because I feel like you guys are so smart and you deserve a little confetti for that. You guys are totally right. It's Alzheimer's. Alzheimer's. Man, Alzheimer's, man, I'm pronouncing things wrong today. Alzheimer's is gradual dementia. It is dementia in general, we diagnose kind of as just chronic progressive. Those are literally the two words that are like, bam, bam, chronic progressive, you're talking dementia. It's a decline in at least 2 cognitive domains. So that could be their memory, their executive function, their language, their processing function, their higher level thinking, their executive, like any of that. There's 7 domains we look at. Any 2 of those really can be considered dementia. And then we add that little qualifier at the end where we say interfering with daily function. Because remember, I said that mild cognitive decline is normal. And mild cognitive decline can also be in any of really these, not really any of them, but most of these, 7 categories. So you have to assess your patient, do a really good workup where you're saying, how much is this affecting their daily function? I said that they like to test on, what's early signs versus late signs. The more it interferes with their daily function, the more it's going to be a later sign. So I like to remember the 5 A's of Alzheimer's disease. You're talking amnesia, apraxia, agnosia, aphasia, and anomia. Those are the 5 A's, which I was not on the board for picking medical terms. It's a lot of Latin, so if you know Latin, it actually really helps. I studied some Latin on Duolingo because it actually helped me a lot with medical terminology. But you can screenshot this right here that breaks down what the 5 A's mean. Because when you see multiple of these, you should start thinking, they may have Alzheimer's disease and they probably need a consult with neurology to get a workup for that. So are they losing their memory? Are they losing motor skills? Are they not able to recognize people they normally, like they see their wife's face or their grandkid's face and they're like, who's that? Objects, voices, places, any of this would be really worrisome for Alzheimer's disease. That's not mild cognitive impairment. If you're having impaired speech or you can't recognize faces anymore, that's not MCI. That's something more that needs to be tested. My tip here for you guys is that if it's early, you're going to have more short-term loss, but their social functioning and their health is pretty much intact. It's one of the things that makes it really hard for the caregivers or the loved ones in patients with Alzheimer's disease is that in the early stages, they seem like grandpa, they seem like their spouse. They look the same, they're still healthy, they eat, they have an appetite, they have a sense of humor, but they start forgetting things and it starts to make them a little anxious as a patient. It makes the family members anxious watching that happen. I mean, it's really hard to your grandpa all of a sudden not remember your name or even your mom or your dad or your spouse. That is something to be really gentle with and empathetic about because that is a huge change. Our brain, that's what makes us who we are. I mean, that's a lot of our personality. And so losing that is very anxiety, depression inducing, and we want to watch for that. So just know that you'll start to just see that, just those personality, those memory changes in the beginning. So like amnesia, and maybe anomia. You start to get like the apraxia, the aphasia later in the disease process. I saw someone said vascular dementia was the next most common type, and that is totally true. These are some of the lesser knowns that are still highly tested on the board, so I like to talk about these just slightly with some of their vivid differentiators. So vascular dementia, literally break it down, guys. Vascular dementia. So it's dementia associated with vascular issues. Usually that client will always have a history of stroke, history of a TIA, history of myocardial infarction. Any of those are going to be associated with them, maybe all three of them. And then they're going to come in and say, I'm getting these like neurologic signs. I'm having some cognitive deficits. My memory is going. That's when you would start thinking, hey, this is maybe not Alzheimer's, maybe it's vascular dementia. And that management is going to be focused a little bit less on a medication that's going to cure them, because we don't have that, and a little bit more on preventing any further issues, further vascular infarctions. Then you've got Lewy body dementia, which is a fun name for me. I like that one. This one presents like Parkinson's. So that's when you want to know. It's also common in individuals with Parkinson. So you can have both Parkinson's and Lewy body dementia, but you may only have Lewy body dementia and it may get misdiagnosed as Parkinson's. They start to have those shakes. And the big differentiator here that is very testable on the board, so highlight this one, is early vivid hallucinations. So they will have a lot of hallucinations where just all of a sudden it's like they haven't even really had that many memory issues when all of a sudden they are having visual hallucinations. And they will be very sensitive to antipsychotics, which is hard because sometimes we prescribe antipsychotics for some of these illnesses and diseases. So you want to make sure that you're getting them a workup with neurology to say, is this Parkinson's or is this something maybe like Lewy body dementia, or is it both? Then you've got frontotemporal dementia. The big change here, and if you think about it, frontotemporal, we're talking the frontal lobe. You're going to see personality behavioral changes first. That is a lot of our personality, a lot of our decision-making capacity right there. And so they will start to just, their family will come in and be like, he has never sworn before in his life, sweetest teddy bear of a guy. And all of a sudden he's really aggressive, like hitting stuff, swearing a lot. It's usually in younger patients, which is really sad. That's when it starts to go warning bells for me that maybe we're dealing with frontotemporal dementia rather than just run-of-the-mill Alzheimer's disease. Mild cognitive impairment, we already talked about this once, but just know that memory complaints are with preserved independent function. That's when you're looking at MCI versus dementia. So if they still have total independent function, that's normal. But we do still monitor these patients. These are the kind of patients that I have them take, a MoCA test every single time they come in, because about 15% of those do become dementia. So they do progress and worsen. So you want to monitor it so that you're catching early issues, and you want to promote just healthy lifestyle stuff. At this point, you don't know, maybe it's related to vascular issues, maybe it's related to lifestyle issues. So just promote exercise, healthy eating, good rest, cognitive engagement. Puzzles are great. Hanging out with grandkids, playing with grandkids, that's amazing for older adults. I always say use it or lose it. If they don't use it, they're going to lose it, and that is going to lead to dementia. So that is something to look at. Treatment, there is really no cure right now for any dementia, but we try to slow it down. So big drugs to know for Alzheimer's disease are the cholinesterase inhibitors like donepezil. That is first line. It does not treat the disease. It manages symptoms. So that is a big indicator, differentiator there that you need to know for boards and also for patient and family education. A lot of times you tell them about this medication for Alzheimer's, they get their hopes up. They're not in the medical world. They think, we're going to cure their family member, especially because they tend to do better. Donepezil is one of those ones that it's like we have to start upping the dose because they kind of get used to it and it doesn't work as effectively for them anymore. And so with that, we want to make sure that we're upfront about the fact that it's not going to work for forever. We will enjoy as much time with our loved one as possible while they do have good cognition. We're trying to slow symptom progression, but we cannot treat and we cannot stop this disease. You want to be upfront about that. Once it starts to become more moderate advanced, you see more the donepezil is not working as much, and they have a lot of symptoms that are maybe physical symptoms, or it's getting pretty severe. You start to see like muscle wasting, frailty. That's when you add in the memantine as the second line drug, which can be used concurrently with donepezil. But that is really only moderate to advanced. So if you see someone who's just barely having memory, it's not a first line drug, it is second line. You want to make sure with any patient that it has dementia, regardless of what type of dementia it is, that we are not prescribing anything that is an anticholinergic or that has anticholinergic effects, because it will worsen their dementia. It causes confusion and it can really make the whole cycle worse. So we really avoid those. In fact, new research is actually coming out. I just read that in Up to Date. That long-term anticholinergic use, things like Benadryl, for example, like my mom loves to take a Tylenol PM before bed to help her sleep better. Long-term use of that is actually associated with increased risk for dementia. So it's been something I've been trying to like wean patients off of if they like are really reliant on Tylenol PM or Benadryl in order to fall asleep. I say, maybe we try some other, like, have we tried sleep hygiene? Have we tried a sleep study to see what else we can do to help you sleep good without it being an anticholinergic? These non-pharmacologic managements, I won't run through all these. It's a lot of the stuff you've done in nursing school. We want to start early would be the only thing I reinforce here. The earlier you start with caregiver support, with physical reminders, with end-of-life documents, you want to get all of that done while they are still as with it as possible so that their wishes are being done, so that they can maintain independence. Remember, I said quality of life, independence, that is really, really important for our patients. So we want to start early. Parkinson's disease, we'll just touch on this one briefly. We know some risk factors for it. We don't have as many dopamine producing neurons. So you would think in your head, oh, that sounds like maybe they have depression. Depression is very, very common. It's one of the symptoms usually with Parkinson's disease is like low mood, but it actually causes our dopamine receptors are responsible for a lot of our movement. So you'll start to see those tremors. They shuffle. If you see the Parkinson's gait where they're hunched over and they don't pick their feet up, they just shuffle. That shaking. They're very rigid. Sometimes they have a hard time starting their movements. So it takes them a really long time and then they go fast once they get moving. And their voice changes. I actually diagnosed a patient with Parkinson's disease earlier this year. And that was their symptom. It was a voice change. It was a vocal change. And I was worried maybe like throat cancer. They didn't have a history of smoking. So I was starting to look into all sorts of things like this. And when we started looking at family history, I sent him off for testing because I was like, he does have a family history of Parkinson's. And I do know that that can be one of the symptoms. So that's what he presented with was those vocal changes. His vocal cords shaked and kind of had this like shaky voice that was lower, quieter. With that, once again, yeah, you're going to need brain imaging. It's something happening in the brain, so you're going to need an MRI, and you can order that or you can refer that out to neurology. Interdisciplinary communication, like I said, is really important in primary care. You want to make sure you're getting them to the right specialist, while also recognizing that a lot of patients are in rural areas and don't have easy access to someone like a neurologist down the road that's going to fit them in this week. So, we do have some meds to treat Parkinson's disease. They've gotten a lot better. So a lot of people will have Parkinson's. My grandmother-in-law, she has Parkinson's disease, has had it for like a decade now at this point and has no symptoms really because she's on levodopa and it's been working pretty good. Levodopa is another one of those ones that just doesn't work forever. So it works pretty good for a while and then it starts to revert and the symptoms come on pretty strong. So those are things to look at there for Parkinson's disease. Quick quiz time again. If you guys want to hop back in our Slido, we'll just take a quick peek at this. As we start to look at delirium. What's the most common cause of delirium in the elderly? Anyone know? As soon as I get a vote, I'll say we can move on. Yep. Okay. Oh, everyone has said UTI, and no one's even misspelt it yet. Oh, sundowners, is that what that one says? Sundowners? Oh, this is so my texting. This is how I text. Yes. Sundowners. Um, Sundowners is a very common cause of delirium. I think research, like most up-to-date statistics say it's going to be an infection like a UTI. Sundowners is probably the next most common with dementia. So great answers there, guys. Awesome job. Acute cognitive changes. Now we're going to look at, we talked about dementia being a chronic progressive. Delirium is the exact opposite. It is acute, it comes on fast, and it fluctuates. So it will happen over hours to days, just comes on quick. It can be caused by an infection, withdrawal symptoms, medication, sundowners, like one of the students said here. So you want to think delirium when there is a sudden change in mental status. So if a family member says it, or you're taking care of a patient and it says all of a sudden they like aren't answering your questions right, or they're being weird, you should be thinking, boom, delirium. In an elder adult, any acute mental status change, we diagnose as delirium. We straight up diagnose it as that until it's proven otherwise. So you just straight out of the gate say, yep, they've got delirium until you can prove that they don't have delirium. That's how common it is in older adults. They just present differently. UTIs was a great example there because UTIs, pneumonia, how I was talking about how chronic disease, acute diseases present differently. That's one of those big ones where they will have a UTI, no urinary symptoms. They don't have to pee a lot. It doesn't hurt to pee, but all of a sudden they're crazy. And it will be their family member that brings them in and says, like, they haven't showered, they smell weird, they are talking gibberish, and you'd think, like, oh no, this is bad. That is usually a sign to me. I do urine, they've got a UTI. So I always order urine on every single patient I have that has an acute mental status change. Even if I think it may be something else, I order urine to rule it out. So great answers there, guys. We manage it by just treating the underlying cause. So that one's pretty self-explanatory. Whatever that underlying cause was, like we talked about over here, where you've got infections, metabolic disturbances like diabetic ketoacidosis or new meds, anticholinergics can cause delirium. You want to treat that. So either stop that new med, get them on an antibiotic, get them electrolytes, fluids, whatever it is that they need to treat the underlying cause. And then we always do supportive care, just like we did as nurses. We reorient. We want to keep the rooms well lit. Sundowners is worse in dark rooms. So we try to keep hallways and rooms well lit. We want to make sure they're getting enough sleep. Sleep withdrawal or poor sleep can worsen delirium or even just cause it in and of itself. And then hydration, as you can see me doing right here. We want to make sure they stay hydrated. Low dose haloperidol. We really try to stay away from antipsychotics for delirium because it is just like, first off, those drugs are really hard on the body. And it just feels like jumping from one extreme to another if we can do other things like behavioral issues. So behavioral intervention. We just save those antipsychotics for when we've got severe agitation, safety threats, they're in there with a knife, threatening to harm themselves or someone else. We're worried about suicide. That is just going to make it worse, especially benzos. Do not give a benzo. I know a lot of people think like, oh, you should prescribe a benzo because they're delirious. They're wandering the halls, talking gibberish, having hallucinations. A benzo's going to chill them out because a benzo's a downer. Benzos do not chill out delirium patients. So make sure that you never combine a benzo with delirium unless we're talking specifically about alcohol withdrawal. That is when that would be appropriate. That's going to be more an acute care setting. So for primary care, you don't really need to worry about it. Okay, cognitive screening tests. We'll run over these quick. These are my top 5 cognitive screening tests. Surprisingly enough, they're also the 2 board certifying bodies, top 5 cognitive screening tests. MoCA and MMSE. MoCA is more specific. It takes a little bit longer to do than the mini mental status exam. I like both of them. I prefer the mini mental status exam because it is really easy to find online and is easier to test, takes less time. But the MoCA, they do say, is a little bit more specific of an exam. So you can do either of those. Mini-cog, that's kind of the one that I say for every geriatric patient. So when I'm doing my annual visit with them and I see them, once a year, I just do a mini-cog. It's just a quick screening, takes like 5 minutes max. just to see if maybe they do need further screening because I didn't catch the cognitive changes. You know, they seem normal to me, but they tested high risk on the mini cog and they need more screening like a full MoCA or MMSE. Slums is another really common one. Slums is more sensitive for mild cases. So while MMSE will pretty much catch anything that is like medium to advanced, it can sometimes miss mild cases because they're still with it enough to pass those test questions. Slums is a little bit better about catching that. So if family members are asking for testing because they're seeing the patient on a more day-to-day basis, but when you see the patient, you're like, I don't think they have dementia. I'll usually do slums because maybe I'm just not picking up on the mild early onset dementia that family is picking up on because they spend the most time with that individual. Clock drawing test is a part of pretty much every single one of these tests. So I put it down here because sometimes you can do just a clock drawing test where you have them draw a clock, put the 12 numbers on it, and two hands. I tell them like, okay, draw a clock, put the 12 numbers on it, and then make the clock show 6 p.m. And so can they draw the little and the big hand showing 6 p.m. or no? That is a really good way to test that visual spatial executive function. So if it's abnormal and the hands or the numbers are misplaced, you're going to want to then, of course, do further testing like a MoCA or an MMSE slums test. Lastly, depression. This is the last big thing before we start to get into falls. Just know that depression is extremely underdiagnosed in the elderly. So it is something that is extremely missed. We write it off. We say, oh yeah, it's normal to be depressed in your old age because you're getting close to dying and your spouse is maybe dead, all your friends are dying. It's not normal. We don't want anyone, regardless of their age, to go around depressed all the time. That is not our hope, not our wish, not our desires. So with that, we want to make sure that we are screening them. It's also missed because they present abnormally. Remember, I said that we talk about atypical presentations in older adults. They have more somatic symptoms. So while a teenager comes in and they'll tell you, oh, they'll put their hands and their head in their hands and they'll just say like, oh, my girlfriend dumped me. I just wish I was dead. There's nothing left to live for. And I'm like, yeah, they're going through some situational depression here. Older adults, they'll have more like low appetite. You know, they're not sleeping very good. They have no appetite. They're not interested in doing the things they used to love to do. Like they love golfing. They haven't been golfing in 6 months. And they may not even put it together that it's associated with a mood thing. They'll just be like, yeah, golfing hasn't really sounded that fun recently. And that's when you start to say like, hey, you know what? These symptoms are a little bit more indicative of depression in an older adult and we want to screen. Why do we want to screen? Because of course we don't want our patients to be depressed and feel awful. I don't want anyone to feel that way. If I could cure depression across the board worldwide, I would do it. But we extra want to screen. We don't want to miss depression because the highest suicide risk in any population is in white older men. They're the most likely to kill themselves and to actually be successful with their attempt. So they tend to do a little bit more aggressive means than women do. We know that about men. And they also they're just it's likely to go underdiagnosed and undertreated, and with that they're just high risk for suicide. So we always want to ask about thoughts in anyone that we've screened that screens positive. Screening I like to do, and that is pretty much mostly the gold standard right now for screening, is the PHQ, personal health questionnaire. There's a PHQ-2, which is only 2 questions, and a PHQ-9, which is 9 questions. I like to start with the PHQ-2. It's a pretty good overarching screening that just asks if anything has changed for them recently, like they don't like to do things they used to love to do, and if they have thoughts of suicide. If they answer yes to either of those questions, you're going to want to go ahead and, of course, get them screened with the PHQ-9 or the Geriatric Depression Scale. They also will often concomitantly have this with anxiety. There, it's a lot of worry. They're worried about their health, about their finances. And buspirone is my favorite medication. That's first line really there. Well, SSRIs are first line, which are also the first line for the depression. But buspirone is a good second line option that's non-sedating. A lot of times people try to put them on something like a benzodiazepine, like a prazolam. You want to avoid those because it is sedating, causes confusion. So those are my favorites there. As far as depression meds go, SSRIs are first line, sertraline especially, escitalopram. We love both of those for older adults. QT, interval prolongation, is common in a lot of depression meds, and the risk increases in older adults for that. So we try to pick the med that has the least QT prolongation, and that's going to be like sertraline. You're going to be your best bet there. So start with the low dose. Remember, I always tell my clients we start really low and don't expect results immediately. It takes up to 8 weeks to really see results there. So you want to keep screening them, make sure that if they have suicidal ideation, you're getting them help in that regard, because you don't want to say like, oh, you're suicidal, wish you were dead. Okay, well, this medication will kick in 8 weeks. That's not good practice. So make sure that we keep a close eye. We're following up during that 8 weeks with patient visits. And then on the board exams, a tricyclic antidepressant is never going to be the right answer. So like amitriptyline, that will almost never be the right answer. You should always avoid those. Super high fall risk, super high suicide risk, and anticholinergic effects. Like a triple no for older adults. So that is a good one to memorize there. You also want to make sure that you are considering therapy. Remember, therapy is always first line, especially it's extra effective when combined with pharmacologic treatment. So we try to do both those if needed. There. Okay, so we've moved on into falls now, which is a big part here with falls, mobility, and bone health. We'll get into this. Falls are the leading cause of injury and death in older adults. So it's very testable on boards. You want to know it. The big takeaway from this slide would be that if they've had any falls in the previous year, which is the question I ask every older adult patient I see, you're going to do a timed up and go test. So a timed up and go test is you have them sit in a chair, stand up, walk 10 feet away from you, turn around, walk 10 feet back, and sit back in their chair. While they do that, you time them. Anything greater than 12 seconds is considered high risk for a fall, and that's when you're going to need to do more stuff. Like you're going to want to do you want to do a full med reconciliation with everything, but just know that that is going to be your best way to test for high risk for falls. If it's more a gait and balance issue than anything else, that's when I start to recommend PT. PT's great for strength training, and they're also just really good for balance. Tai Chi as well. I know that my gym that I go to over here in Utah has something called the Silver Sneakers Club, and they go in a couple of days a week, and they will do exercises in chairs, standing, Tai Chi, which is really great for balance. Falls lead to death pretty much, which feels like a bit of an exaggeration and pretty dramatic, but it is true. So the more individuals fall, the more chronic health conditions they have and the more injury. So that is super important there. Prevention strategies, USPSTF recommends strength and balance training for everyone over 65. So you can just leave it at that. The recommendation that's, grade A evidence is that everyone over 65 has strength and balance training at least a couple days a week. So you need to know that. Orthostatic hypotension, it's one of the changes of the body. We know we have autonomic changes. We don't produce as much aldosterone. Blood pressure is lower. They have less fluid. Cardiac output's less. We have arterial stiffening like we talked about, so they don't adjust to blood pressure changes as well. And the thing you need to think of as practitioners is orthostatic hypotension equals falls. So we always want to make sure we're testing this in anyone who complains of dizziness when standing. And I just tell every one of my patients that's older that anytime they change positions, whether that's laying to sitting, sitting to standing, or standing to laying, that they do it slowly. So, I say, when you get yourself out of bed, take your legs over the side of the bed, put your arms up, give me a good little stretch, breathe there for a second, put your non-slip footwear on, your nice little cat slippers before standing up. That's going to significantly reduce falls. You also may want to order assistive devices, which when I was in grad school, this was always a question for me that I struggled with, like when do you order assistive devices versus when do you not order it? If it is affecting their quality of life and they have had falls in the last years, I always order an assistive device if they're okay with it. And I go a cane if it's more a weakness on one side of the body, or I go a walker if it's generalized. So any of my patients that have generalized instability that's like kind of on both sides, one's not way bad and the other's perfect, that's going to want a walker. So education there. Bone screening, this one's going to be really important. USPSTF recommends a DEXA scan for women 65 and older about every 1 to 2 years. We start that younger for individuals that went into menopause early. So the average age for menopause is 51. So if they start a couple years before that, I start worrying that, they didn't get that estrogen that's really good for bone health. And so we want to screen them a little earlier. And then how often we rescreen is going to be dependent based off of what the reading shows. A lot of times it will give you a recommendation like, yeah, they should come back in a year. They should come back in 6 months because it was so bad, or 2 years. Men don't get DEXA scans nearly as frequently as women do, but we still do recommend them in individuals over 70 if they have risk factors. So, for example, if they've had a pathological fracture where a bone just breaks out of nowhere, we would order a DEXA scan. So with DEXA scans, this is something you need to memorize for the boards. You need to be able to differentiate between osteopenia, osteoporosis, and normal bone density. So normal's -1 to 1. -1 to 2.5, so 2.4 is osteopenia, and then 2.5 or less is considered osteoporosis. And as you start looking at actual osteoporosis, so if you have that T-score of 2.5 or worse, or you have a FRAC score, which they'll give you on the DEXA scan, of 3% or greater that they fracture a hip, that's when you start treatment. And treatment, the first line is actually going to be calcium and vitamin D. I know everyone thinks Fosamax, Fosamax, Fosamax. I see a lot of patients on Fosamax, but it actually is second line. We start with calcium and vitamin D, and then we add Fosamax if that is not helping with bone density, or maybe they have a lot of risk factors and we're worried about it. Some board stuff to know and clinical pearls for Fosamax. It's taken once weekly, which is really nice for older adults that don't have to remember to take it a lot. It needs to be taken first thing in the morning on an empty stomach with a full glass of water, and then they need to sit upright for 30 minutes. They take it first thing in the morning because they haven't eaten anything at that point, and also you're most likely to stay upright later in the day then. Whereas if you take it before bed, you're going to lay down, and that's going to cause that esophagitis. Bisphosphates are really irritating to the esophagus. And so it can, I have seen patients that it burned a hole in their esophagus, very dangerous. So you want to make sure that you really drive home that education of sitting upright. And then also it's renally excreted. So if estimated GFR is less than 30 to 35, we don't give it at all. So that's something important to know for your board prep. Now we've got a practice question. So we are running really low on time, so I'm just going to give you guys 30 seconds here. Right here, we will go to this next one and pick your answer. FRAC score of 10%, hip fracture at 4% over the next 10 years. T-score is -2.8, which you guys now know is considered osteoporosis then. It's less than 2.5. They decide to prescribe Fosamax. So what indicates a need for further teaching? So remember, guys, when we look at this, you want to make sure you don't miss that root cause the question there that says, what indicates a need for further teaching? So that's where it can kind of get tricky, because sometimes I'll read answer A and answer A is right. I'm like, oh yeah, that's what I want. What you're looking for is the answer that's wrong. And it looks like a couple of you guys have put your answers in there. Answer A, you guys are totally right. I put the wrong rationale here. Answer A is correct. Taking it at bedtime is the wrong answer. You do not want to take this at bedtime because it will cause the esophagitis because they lay down. Sorry, I lost my train of thought there for a second. Skin changes, we're going to blow through these quick. Most of these are not super worrisome, but they are very common in older adults, so you need to know them both for clinical practice and your boards. You've got solar lentigo or lentinges. Those are liver spots. My mom calls them age spots. You'll hear them by all of those. They are flat and they're benign. So that's what you want to know. They almost look like a little tan spots. So kind of like freckles almost. They get a lot of them as they age. It's just cosmetic. So they're not dangerous. They are not cancerous. They cannot become cancer. That's the big thing to know for these solar spots, is that it will not progress to cancer. So they are A-okay there. you just want to tell them to avoid too much sun exposure. It will make them worse, and to wear a pretty high SPF on their body, especially if they're going outside. Stasis dermatitis on the other end, where this one was benign, not worried about it at all. Stasis dermatitis is a pretty good indication of heart disease and poor peripheral perfusion. So you're going to see this thickened skin with these ulcers. They're not going to heal as well. It's going to be scaly. And with that, you're going to want to treat with the fluid gets stuck down there and then there's not a lot of blood flow. And so that's why the skin turns a little necrotic. So that's what so the skin turns a little necrotic. That's what's happening there. And so you're going to want to treat the symptoms there and get them probably into a cardiologist to check for heart disease. Actinic keratoses, you've got red scaly skin lesions. They look like they could almost flake off or peel off. That's kind of the big indicator there. Sorry guys if my internet is being a little sketchy. I hope it's streaming okay for you guys, but in case it's not, this will be recorded and you can watch it again later. These are a precursor to squamous cell carcinoma. That is like almost a guaranteed board question. Like I'm not going to say that really because I'm not allowed to say that, but I am saying it is very commonly tested and it's very commonly tested because it's very important information to know. They look benign because they kind of almost look like a liver spot because it's just kind of this area of dry, flaky skin that doesn't go away, but it can progress to squamous cell carcinoma. So we want to treat it with cryotherapy, excise it, or you can even do the fluoroquilicil that like makes all their skin peel off. That one I like less because it is kind of pretty painful and takes longer to do. So that's not my favorite. And then we have senile purpura. These are just bruises. So it's just because as we age, our skin thins, the blood vessels get fragile, and then we bruise easier. So it heals over time. It heals over time, and they're totally benign. We're not worried about them. Geriatric syndromes. Incontinence is that sudden urge to urinate where your bladder is just overactive. You've got those risk factors. We know age is a big one, but also bladder irritants like caffeine or alcohol really contribute. Obesity, constipation, all of those. You want to get a thorough patient history and then know that treatment is usually non-pharmacologic first. So you want to start with the non-pharm stuff and then you can progress from there as needed. So relaxation techniques, stopping caffeine. The big board stuff to know for this one, since we're running out of time, is incontinence is not a normal part of aging. So if an individual comes in and they tell you, yeah, they wet themselves, but they're old, so that's expected, that's not expected. We do expect them to have to use the bathroom more, but we don't expect them to pee themselves, to urinate themselves. That's abnormal. So we want to make sure that we know that and that also we can distinguish the different types. Like loss of urine when laughing, that should make you think stress. If they're talking about all of a sudden they have to go really strong out of nowhere, we're talking urge incontinence. If they have a history of diabetes, they're constantly dribbling, we're looking maybe at more overflow or neurogenic. So that's what you kind of want to be able to differentiate the two there. Oxybutynin is the med I see the most used. It is kind of first line med wise, but it does have anticholinergic effects. So try to avoid that one if possible. If we can get them into a urologist or do non-pharm stuff and that's effective, we want to start there. Chronic pain, osteoarthritis pain is one of the most common. That's going to be first line acetaminophen. That's going to be what you start them with. I know we're used to just giving NSAIDs out willy-nilly. We don't give NSAIDs really to older adults. That's on our beers list of things to avoid because of that kidney stuff. It's hard on their kidneys. So we try to avoid that if we have to use NSAIDs because acetaminophen's not doing the job. We try to start with topical like diclofenac gel because it kind of minimizes the systemic, or we do it short term and we put them on a PPI as well to prevent gastric ulcers. And I mean, there's not a lot we can do for kidneys other than use it short term, but for those gastric ulcers and GI bleeding, we definitely want to make sure they're using it concurrently with a PPI. Neuropathic pain is kind of one of the other most common types of chronic pain. Usually that's caused by shingles if you're talking post-herpetic neuralgia, or it is caused by long-term diabetes. So that neuropathic pain feels like the pins and needles, really hurts in their legs, sounds awful. First line there is gabapentinoids. We don't have a great drug for neuropathic pain. I would tell you that in the next 10 years, I think we'll come pretty far with neuropathic pain and how we treat it. But as of now, gabapentinoids are our first line. And then TCAs are our second. And I know that both of those are on the beers list for drugs to really avoid. So that's why I'm saying it's like we don't have a great option. Gabapentinoids cause a lot of sedation, so we take them at night. And TCAs have overdose risk, anticholinergic, so there's a lot of risks with them. So we try to avoid them, but if your patient's in chronic pain all the time, it may be something that we start at some point. And then lastly, with chronic pain, I know you guys say chronic pain, you think opioids. We really want to reserve that for severe acute pain. Or if it's pain that is unresponsive to every other measure, you want to do it for the shortest duration possible at the lowest effective dose. And that should be something that is like co-prescribed with something for constipation, because we know older adults are already high risk for constipation and opioids cause constipation, but also just that we're meeting with them frequently. Controlled substances require frequent meetings to make sure that you're not just getting refills, that we're double checking that it is still necessary. Because remember, lowest dose, shortest duration. An opioid is almost never the right answer for a test question, because it's just, we're really trying to move away from opioids due to all of the risks associated with respiratory depression, addiction, etc. So first line is going to be always adjunct therapy. So PT, hot and cold therapy, TENS units, etc. Sleep problems in older adults. Insomnia does increase with age. Remember, we talked about recognizing the difference between insomnia and excessive daytime sleepiness, and also just changes to the sleep-wake cycle. Because insomnia is multifactorial. All of those things can contribute to it. As far as treatment goes for older adults, we want to start with sleep hygiene and then move to medications later. And for medications, we really want to, like I said, avoid anticholinergics and benzodiazepines. Those are a last resort. The boards will always expect non-pharmacologic measures first before we step in to those pharmacologic interventions. Nutrition screening, we want to do that every visit. Unintentional weight loss is 10 pounds in 6 months. That's kind of a number to memorize for boards. Anytime a client tells you that they've had unintentional weight loss over the last 6 months, you want to make sure that you are screening for further issues. Like, do they have good dental health? Can they chew their food? Do they maybe have an underlying disease we've missed? Are they considered frail? So we don't really give meds. We mostly just do oral supplementation with food, like Ensure drinks or protein bars, if their weight is less than ideal. If we're starting to get to end of life things like hospice, end stage disease, that's when we start to do things like mirtazapine, an antipsychotic, because it stimulates the appetite. But it's not first line, definitely not. For that case study here, we will just, we look at really, what are your next action going to be? You want to further eval. So you want to review all those things. And sometimes labs are indicated, but not always. And then lastly, little board pearl for you here. Frailty is a syndrome. It's a combination of weakness, slowness, unintentional weight loss, low activity. It is all sorts of those things. So when we say an individual is frail, we're not just using a description to describe how they feel. We're actually literally saying that they have an underlying syndrome that is weakness, slowness, and frailty is one of those things that you want to definitely be able to observe on your boards, that you can recognize and say, hey, you know what? This isn't normal. They're weaker than normal, and then go from there. So we will end there with frailty, guys. There's a lot more to know about geriatrics. It's hard to sum it up in an hour and a half. I'm teaching this same webinar again next month, and we'll get into a little bit more of the stuff that we didn't get to touch on today. If you have any questions in the meantime, feel free to email me at nursepractitioner@archerreview.com. I'm full-time here at Archer, and I am super passionate about student education and making sure that you guys feel prepared for boards. It was so anxiety-inducing for me that I got really anxious about it, and I want to prevent that in you guys. So feel free to email any questions. I can go over our options with you for QBank, On Demand, SurePass Pro. Um, I can even be upfront and let you guys know that when I took my boards, I exclusively used Archer Reviews NP products, and that was a while ago. We've done a lot of updates and rebuilding, really beefing up our question bank. It was the only thing I did, and I felt really good past my boards the first time around. So as an anecdotal response for you guys as well, I love this product. I think that it is a very strong, well done product. If you want to hear more about geriatric issues and how we care for geriatric clients, you go ahead and scan this code right here to register for SurePass. Or you can connect with us on all of our social media. We do free webinars like this, like 2 to 3 times a week with continuing education credits. So if you don't want to miss any of our other future webinars, we post about them every week and the day before so you guys can sign up. So join our social media accounts there. And then let's end with just one last Slido question. We didn't get to all of them. I just want to see if you guys are feeling better. Did this stress you out? Are you feeling a little bit more overwhelmed? Or do you feel maybe like you're feeling better, you feel good? That Okay, good. I like to see those. I like to see a little bit of improvement. I mean, this was just a 1.5 hour session. If anyone needs tutoring, you can email and sign up for tutoring. We can get you in a small group or in private tutoring sessions to kind of go over some of this material a little bit more in depth if you're struggling more. So I'm glad you guys found this to be effective. That is a big increase in the average score of how confident you guys feel. So even though we didn't get to touch on everything today, I'm happy to be here and happy to have you guys here. Thanks for joining today, and I hope to see you at another one of our webinars in the future. Thanks, guys. Have a good night.